But thank you all again. Welcome. Like I said, this is the fourth and final webinar in the SDOH Academy's 4-part webinar series. And we're talking about empowering change, innovating and scaling for a healthier tomorrow in the face of emerging social determinants of health. So just a little bit of housekeeping. All participants are muted, as you've probably noticed. And this is to limit background noise. Again, there's a large audience, so we want to make sure that there's not a ton of background noise. Please use the Q&A or chat box to ask questions during the session. The webinar is being recorded and materials will be emailed to participants and registrants. And we would love to hear your feedback. So please do fill out the brief evaluation at the end of the session. It really means a lot to all of us. The Social Determinants of Health, or SDOH Academy, is a HRSA-funded virtual training series designed to help staff from health centers, health center-controlled networks, and primary care associations develop, implement, and sustain SDOH interventions in their clinics and communities. And the power of the SDOH Academy is that it does not focus on a single intervention. Instead, multiple HRSA-funded national training and technical assistance partners work together to offer coordinated curriculum on multiple community-based SDOH interventions. And we have a ton of resources that we have created as a group. And so we encourage you to check those out at sdohacademy.com. So like I said, there are a bunch of us national training and technical assistance partners that work on this. And when we work together, we're able to really maximize that impact of health center programs, increase access to high quality comprehensive primary health care for underserved populations, support HRSA awareness of various issues impacting health centers and special populations, support health centers to identify and implement evidence-based and promising practices, and then leverage those health center shared experiences and data to improve health outcomes for patients. The national training and technical assistance partners that are involved in the SDOH Academy are all listed here. There are a lot of us. I'm not going to list us all, but we work together. And again, this is to really leverage those HRSA funds to create as even better resources for all of you. So we're from all over, and because of that, we want to know where you're from. So you can go to menti.com and enter the code 39678947, or if you have a smartphone with you, you can pull up your camera app and use that QR code, or the Mentimeter code is also entered, will be entered in the chat in just a moment. And to answer one of the questions I'm seeing in the chat, yes, the recording will be made available afterwards on that SDOH Academy webpage. So it looks like you should be able to access the Mentimeter from the chat. So now I'm going to share that screen so we can see as folks are inputting where they're from. We're coming from all over. Which I love. And again, there's a huge amount of us on the webinar, and this is just a way for us to think about, you know, we're all coming from different parts of the US and US territories. And so, but we're coming together to learn here today, which I love. Answers still coming in. We're missing Region 8. Gotta come and represent. Yes, some Montana folks. Nice.
There we go.
Yeah, this middle of the country here. And then, yes, I see in chat, we also have some folks. So nice. Love that. So part of this, like I said, shout out to my Colorado friends. Like I said, this is for us all to, you know, get to feel close to each other, and we'll be using Mentimeter throughout. So don't close that window. We'll come back to it. But we love to see all these answers in the chat and on the Mentimeter of where we're all coming from. It's beautiful. So your presenters today, got to go back to the actual slide. That's the thing. There we go. So my name, I've already been talking for a while, but my name is Helen Ravernier. I use she, her pronouns, and I'm the Associate Director of Workforce Development at ECU Star Center. And my fellow NTAP presenter is Megan Urkel, who also uses she, her pronouns, and who's the Senior Project Manager of Health Outreach Partners on our planning team. And a special thanks goes out to Sarah Mitnick and Theresia Lyons-Clampett from the National LGBTQIA+ Health Education Center and Migrant Clinicians Network, respectively. Thank you so much for your teamwork as we got this webinar together. And then our guest presenters today are Dr. Maricel Pagan Santana and Diana Liu. Maricel Pagan Santana serves as the Director of Environmental and Occupational Health of Migrant Clinicians Network in Puerto Rico, where she leads and coordinates MCN projects related to the climate crisis, occupational health, and emergency response. She's also the organization's lead for the Caribbean office. Dr. Pagan Santana provides technical assistance, training, and tool development for community health centers in Puerto Rico and the communities they serve to address disaster-related issues and health-related impacts. And then Diana Liu is the communications manager at the San Francisco Community Health Center. Diana has a background in digital arts and media and believes in the power of elevating transformative health equity work to drive social change through strong communications. At San Francisco Community Health Center, Diana works to ensure the incredible work we do is reflected in our digital organization. Prior to joining San Francisco Community Health Center, Diana served as the Director of Communications at the Praxis Project, an intermediary organization working to bridge the community health, to bridge the work between community organizing and the conventional public health profession. Diana also has a decade of experience in providing technical assistance and training and held a variety of roles at Health Outreach Partners. Diana also coordinated an LGBTQ wellness program at Apicha Community Health Center, the beginning of their career in community health. Diana has a BA in arts from Sarah Lawrence College. So we're so excited to hear from these wonderful guest speakers. Our learning objectives for today's session are to identify key components of innovation in addressing social determinants of health and to analyze examples to understand what it means to be innovative in healthcare practices, to evaluate strategies for scaling innovation in healthcare, recognizing common barriers to scale and exploring methods to overcome them effectively, and then consider resilience in innovation by understanding the importance of failure as part of the process, learning how to pivot and correct course when faced with challenges, and applying resilience techniques to sustain innovative efforts in addressing social determinants of health. So with that, I will turn it over to my colleague, Megan Urkel, to talk about what it means to be innovative.
Thanks, Helen. Welcome, everybody. It's so great to see. We're coming from so many different parts of the country today. I really just want to kind of take a step back and really put the question out for our second poll of what does it mean to you to be innovative? You have the question right here. You can scan the QR code again. But yeah, we often hear the word innovation or innovative, but would love to hear, maybe in your health center or in your community. Bold, love that. Hear any more in the chat? Or committed? Absolutely. Adaptable, creative, out of the box, exactly. Shaking up systems. Another thinking outside the box. Creative, open-minded. Taking community input, having tough conversations, disruptive. I love that word in the chat. Yes. Could go back to the slides. Thank you so much for participating. I think it's just good to kind of ask that question because oftentimes, when we think about innovation, next slide, Helen, we think of technology or we think of, a mobile app, but oftentimes public health innovation can be a new solution, a policy, a creative process, a new product or program that has the ability to transform systems and increase impact. And over the next decade, we have an incredible opportunity to eradicate extreme health disparities in the United States. But that's not going to be easy. So finding innovative solutions to complex challenges will be essential to drive progress toward the Healthy People 2030 goals and enabling millions across the country to improve their health and well-being over the next decade. Next slide. So when looking at innovation in regards to social drivers of health, innovation has been and will continue to be pivotal for reaching sustainable scaling solutions to our Healthy People goals, specifically related to SDOH. And just a reminder, SDOH includes things like safe housing, transportations, racism and discrimination, education, job opportunities, access to nutritious foods, and our collective environment, including polluted air and water. And we know that these SDOH and underlying structures really contribute to the wide health disparities and inequities that we see in our communities. The services to address social needs will need to exist outside of our traditional health systems, and such needs are often deeply entrenched in issues of poverty and inequity. And often, as someone said, a lot of these innovations are disruptive to the current systems, and we see in health centers and communities that you all are doing really innovative stuff, and we just really want to highlight and bring attention that how you can scale and really sustain to really make impactful change in your community. Next slide. So before I bring it back to Helen to really talk about scaling solutions, our scaling innovations and really what that means, I kind of just want to ground and look at different a wide range of principles that we found to really be successful in regards to innovation. The first is really having a solid understanding of the problem. We talk about this a lot in public health. What are the needs of the communities, doing landscape analysis to really address and understand the problem, and then using that research or evidence and data to drive that decision making. We know that innovation is often an intelligent risk. We're doing something new. Like someone says, we're going outside the box. And with that, we're going to fail. And that's okay. It's really all about embracing the failure, learning from our mistakes, and continue to be resilient. Most importantly, we really want successful innovations to be locally and community driven. Oftentimes when we see innovation in communities or in community health centers, a lot of it is coming from the community, these ideas, these solutions. So really, again, having a solid understanding of the problem, talking to members of your community and getting their input into having these creative ideas. A couple more: facilitate cross-sector and community collaboration. We know that community partnerships are so essential in everything that we do, and oftentimes we have the same goal in mind. So really looking at, different partners in the communities to kind of be innovative and do cross-sectoral ideas to really come up with a really creative solution with the same end and goal. And lastly, in order to scale, which Helen will talk about, really having that vision of scale before we really look forward to taking off. I think oftentimes, people look to scale too early, but Helen's going to talk a little bit more of how different steps, and we really want to make sure that failure is always a part of that. So I'm going to take it back to you, Helen, to talk a little bit more about sustainable scale of innovations.
Beautiful. Thank you. And thank you to everyone who's continued to put those thoughts into the chat. I'm loving the engagement there. So as Megan really alluded to achieve the level of impact that many are looking for from innovation, we can't just be creating something new and then just hope the results will come. We need to commit to systematically pursuing those results by scaling viable ideas into products or services that create value at scale. And that's, of course, easier said than done. So if we think it's hard to come up with innovations, try scaling one up. But that's what we're here to talk about and think and do. So to explain what it means to scale innovation, it's first important to take a step back and look at the life cycle of innovation. So to begin, every innovation starts from a rough idea or concept, and often you may have a specific goal in mind or problem to be solved, but sometimes it can just be a cool idea that you think could really make an impact. And from there, you first need to validate that the idea makes sense and then build a product or a service that meets that real need. And so with those steps taken care of, the next part is to scale the innovation. And at this point, we have all the pieces in place to create value, but we haven't yet unlocked that value for the vast majority of the potential consumer or patient, depending on, what the innovation is. And so scaling is the part where most of the value creation and impact comes from. So with that said, we can really define scaling an innovation as the process of expanding the presence and the use of the innovation to be as widespread as possible to maximize that impact. And it's the process of translating an innovation that's proven to be effective into widespread practice. And so while on paper, again, that sounds fairly straightforward, it's actually extremely important to first clarify the vision of what successful scaling looks like for your innovation and what metrics you'll use to measure your success there. And for those in the business world, which, as Megan mentioned, that's where we often think about innovation and see it, it might just be revenue or profit. But here in the healthcare sector where we all sit, it could be the number of patients served, improved clinical measures, the impact you've delivered, and so on. So really, it's really important to think about what those metrics are. And most of these metrics are, of course, related, but when you start with the end in mind and gradually work backwards from there, you're much more likely to succeed because everyone in the organization will know what it actually is that you're aiming for. And then again, with that goal in mind, you can start narrowing in on the methods required to get there, which is what we'll be focusing on next. It is important to, of course, thinking about our barriers to scaling innovation. Scaling healthcare innovations can take years, and in part because of the complexity of our healthcare system. And some of the most common barriers to scaling innovation are listed here: a lack of resources, lack of access to talent or qualified personnel, the inability to respond rapidly, and then, of course, cultural resistance. But certain characteristics have been found to make innovations more readily adopted into healthcare practice. And the literature really highlights 6 key attributes that facilitate successful implementation of innovation. And these are listed here. So we've got credibility. So for innovations to be scaled successfully, they should really be built on a strong evidence base. Relative advantage: innovations that have a clear, unambiguous advantage over a current practice, like one that improves health outcomes, reduces clinician workload, or reduces costs. Those are more readily adopted and implemented. Simplicity: innovation complexity can really hamper scaling efforts. When innovations are perceived as straightforward, even when they're supported by complex science, potential adopters are less intimidated. This is not to say don't work to scale things that are complex, but we're just thinking about how we can mitigate some of those barriers. Testability is also really important. Innovations may be adopted and assimilated more easily when intended users can, with minimal investment, pilot test and experiment with that innovation design. Observability: so those readily observable healthcare innovations generate discussion among potential adopters, and that helps to spread new ideas. So without observability, stakeholders may not easily understand the relative advantage of an innovation. Innovations aimed at prevention often have a particularly slow rate of adoption because the benefits of an intervention are not immediately observed. And again, that is not to say we shouldn't be investing in innovations that are about prevention, but in terms of showing and finding ways to make these innovations more adoptable. It's about thinking about how you can make that observability higher, even with a preventative measure innovation. And then compatibility. So when innovators are compatible with current healthcare practices and reimbursement structures, they're more easily adopted. And again, I don't want these to sort of hamper us or bind us in. We just need to be thoughtful as we're innovating and scaling those innovations about how we're communicating, how we're showing these things, and what might be a barrier as we hope for more adoptability and adoption. So a healthcare organization's decision to adopt and sustain a scalable innovation really does, of course, depend on several factors. Commitment to change from leaders, both administrative and clinical leaders, is, of course, critically important. Again, the literature describes the importance of making the business case to leadership to show the advantage of a particular innovation, not just in terms of those 6 characteristics, but also in terms of justifying why the resources should be spent on a particular innovation rather than other priorities, and showing how the innovation, if successfully adopted, will fulfill the organization's goals. So supporting a quality measure or helping the organization achieve their community outreach goals or whatever it is. And then organizations also need the internal capacity to embrace change. And I know in this environment, we talk a lot about change management. This is really critical here. So implementation may really require organizations to develop or modify health information technology systems, purchase equipment, hire and train staff members, or coordinate with external organizations. And innovations aimed at prevention tend to be time intensive for clinicians, and many settings, especially community health centers, and other entities that serve the most vulnerable populations, are also challenged with competing demands that it can be difficult to focus on wellness and disease prevention. However, when an innovation is coupled with those incentives, like funding to pilot test an innovation or insurance reimbursement to pay for an innovation once implemented, uptake does tend to be more feasible. So as we're thinking about this, these are the things that we need to be advocating for with our leadership to get that organizational buy-in and have that internal capacity for change. Organizations can use several strategies to really scale up their innovative ideas successfully. So as Megan mentioned as well, developing partnerships with other companies or organizations is a great strategy that can help organizations grow and reach those greater heights. By collaborating with these other groups, we can really leverage each other's expertise and resources to develop those creative solutions and bring them to the market or to our health center patients faster. Another strategy organizations can use when scaling up their innovative ideas is open innovation. And open innovation involves leveraging external sources of ideas, such as patients and research institutes, to innovate quickly and cost effectively. And organizations that implement open innovation have increased chances of success because they can tap into a larger pool of creativity than if they had tried to innovate solely in-house. And then organizations can also use experimentation as part of their scaling strategy by testing novel concepts, by running pilot programs for new services. Experiments really allow organizations to examine the viability of an idea before investing in it, which might save them time and resources if the experiment reveals flaws in the approach. And then finally, organizations need to ensure that they have those proper processes and systems in place when scaling up innovative ideas so that they don't experience any hiccups along the way. And this includes embedding strong project management across teams, setting those really clear expectations around timelines and deliverables, developing robust communication protocols between stakeholders within and outside the organization, and more. And these processes help organizations maintain control over those projects while mitigating potential risks associated with scaling up innovations. So I know that's a lot of information to throw at you, but these are all sort of some of the things that we need to be keeping in mind as when we have those great ideas, we work to scale them up. So next we have another couple of Mentimeter questions for you. The first is, where are some of the places that your health center or your organization has had the most challenges? And again, you can access the Mentimeter through the chat. Again, the QR code is up, and I'm going to bring that up so that you can be answering the next question. So again, where are some of the spaces that your organization or your health center has been facing challenges, etc.? Also, I'm seeing in the chat funding, integrating CHWs into clinical settings. And then I saw in the chat a question about sound quality. Does someone want to get, is my sound okay?
There's just a little echo, maybe a little bit of scratching. I think turn the volume down just a tad and that might take care of it.
Okay.
I think it just might be feeding back from the screen.
Okay. Okay. Interesting.
It was barely noticeable on my end, but
okay.
I think
Good to know.
Yeah, thank you.
Great. So yeah, we can see this word cloud keeps shifting and changing, but staffing, staff burnout, retention, these are coming up to be some of the biggest pieces. We've also got, it just keeps changing. Resources, transportation are coming up as larger, participant retention, funding, and funding showed up in the great on the sorry, in the chat. I'm trying to keep track of the chat and our word cloud. And yeah, like Maricel said, I'm trying to keep my mic away from my sweater because I'm worried some of the scratchiness could be from my sweater. But it is 29 degrees out here in Colorado, so I need a sweater. Anyway, yeah, I'm loving again that it's changing so much, which shows that like there are a lot of challenges and we're all facing a decent amount of the same challenges, and that leadership buy-in, scaling back on DEI initiatives or promises, that's really interesting. So with all these challenges in mind, which again, of course, we're all facing challenges all the time, but now I want to know, how have you turned any of those challenges into an innovation, if you have? And if you have, how have you scaled those innovations? We've all got a lot of challenges, but how are we creating answers to these challenges? Got cross training in the chat. We also have partnerships with funding orgs and community resources, identifying allies, trying to be patient centered, housing resources, workflow restructuring. I'm going to start to slide down here. Am I? There we go. Partnerships, demonstrating improvement, collaboration, a lot of partnerships, fundraising, growing your own, incentivizing time. Beautiful. And you can all continue to put these in, but I think this is a great example of how, and we'll talk about this next, but how resilient the health center community and the health center program and movement are to challenges. And that's not to say that the challenges aren't real and that we don't need real support. And it's really vital to remember and see all the ways that we take challenges and we innovate and scale those innovations from there. So thank you all so much for sharing. So next, I want to quickly talk about having resilience to innovation. And guess what we're going to do? Go right back to Mentimeter. So hopefully you didn't close that out, but the next question is, what are some of the most important factors, in your opinion, for driving innovation in today's fast-paced world? So how are we driving innovation? And again, you can put those in the chat as well. Yeah, and Bethany in the chat says it's very curious to see what resources folks have used for burnout trainings. So yeah, innovating around burnout is really interesting. And then Here in the word cloud, we've got collaboration, teamwork are coming up as large pieces, but we've got other ones coming up: accessibility, teamwork, technology, staying up to date on technology seems to be a really big one, both in the chat and in our word cloud. So yeah, these factors are impacting all of us, and they're really yeah. Oh, and I think that was Bethany made a really good point that yeah, when we're talking about technology, we're not just talking about AI. And of course, AI is really, it will be continue to impact us, and it is itself an innovation and can potentially lead us to other innovations. But also, there is so much technology beyond that, valuing opinions across generations and not dismissing them. Love that. Beautiful. So yeah, again, we all are having these various factors driving things, and we'll continue to innovate through those lenses. So my next question, maybe a leading question: how important do you believe resilience is for fostering innovation in a rapidly changing environment? We're leaning on the important end of things, which I love, because again, that's the next thing I'm going to quickly talk about before handing it over to our wonderful guest speakers. So yeah, we think that resilience is important. And of course, when we're talking about we talk about resilience so much when we talk about burnout, mitigation, etc. But I think, as I'll talk about in the next few slides, resilience for innovation can be really useful. And it seems like you all already agree, which I love. So I'll go back to the slides. So did I skip a slide? No. So it's really important to note that innovation requires plenty of trial and error. It may seem counterintuitive, but repeated failures can and often do, of course, lead to success. And so every time we try something new and fail, it provides valuable information about what went wrong, and just as important, what went right. And from that, we can make small changes and try again, continually learning and innovating. And as Baba Shiv, professor at Stanford Graduate School of Business, notes, if you're trying to solve a problem, there are potentially hundreds of possible pathways to take, but only a few are going to lead to the appropriate solution. And the only way to discover that is to try and fail and try again. And so experimentation and failure are essential to innovation, because by its nature, innovation is an unknown that can only be discovered through trial and error. So when we're thinking about how to be resilient in the face of innovation, it's important to note and hold up failure as the mother of innovation and as this really important, really key element that we can't move forward without. So I think that's an important piece when we're talking about being resilient in the face of this. And so thinking about too, how can we embrace failure? Failure can be really hard to talk about. We've been taught to hide it for so long. And so to reframe our relationship with failure, it can help us to remember how we dealt with roadblocks as children. And so as kids, we were naturally inquisitive, we're eager to try new things in the name of play. And when things don't necessarily go our way, instead of dwelling on what didn't work, we're quick to move on and try something new and figure out what might work. And so that is not to say it's not important to examine and look at what didn't work as a way to figure out what might work instead. But instead of dwelling on that failure, we can, thinking of it in this way that we thought that we were as children and played, can help us jump right into new approaches. So to do this, it's important to silence our inner critic. Instead of dwelling, like I said, instead of dwelling on what's wrong, we can really take those lessons learned, collect the valuable data, do that detective work, and really explore why something failed. And then from there, try to figure out what could be done differently. And then value progress. So acknowledge the progress we've made, even when the result isn't necessarily ideal, and make note of how past lessons helped us improve. And then thinking about failing the right way. Of course, now that we're all inspired to, get started on things and fail, and then jump right back into it with this idea of being resilient to innovation, or resilient in the face of the failures that come from innovation. It's probably time to acknowledge that there are different kinds of failure, and that only a few are helpful in fostering innovation. So this is a failure spectrum that was developed by someone at Harvard, the Harvard Business Review. And so abject failure, for example, is not the kind of failure that leads to innovation. Quite the opposite. This is that deep, dark failure of lost jobs, lives, livelihoods. And so we're not aiming for abject failure. But moving along the spectrum, version failure involves little failures that lead to gradual but significant improvements over time. And predicted failure occurs when failure is a necessary step in the design process that clarifies the right way forward. And so these two types of failure can really lead to remarkable innovation and invention. And that's because they're failures that we can learn from and improve upon. Failure can be useful. It can be a useful tool that gives us the perspective to try new approaches and see what works. And that's how innovation occurs, through those actively testing out those new ideas, and having safe spaces to fail potentially. And so having an innovation mindset and resilient responses go hand in hand. So as we've discussed, we think of an innovation mindset as the ability to come up with new ideas, fresh approaches to problems. And it is about being creative and nimble and forward thinking. But above all, it's about being collaborative and open to trying new things and even making mistakes. I think that's the key takeaway of this section. And so an organization that demonstrates resilience is able to navigate challenges. COVID-19 is a great example, social unrest. And then they're able to respond to those changing circumstances with intention. Resilient organizations leverage the expertise of staff, they listen to their community, they reflect on systems and processes, and they learn from mistakes in order to pivot, adjust, and move forward with intention. So with all that in mind, I'd like to pass it over to our first speaker, Dr. Marisol Pagan Santana, and have her talk about innovating for the climate crisis. So take it away.
Thank you. My name is Dr. Pagan Santana. I'm the Director of Environmental and Occupational Health at Migrant Clinicians Network. And I want to piggyback a little bit on the conversation that we're having about being innovative and resilient. We know the climate crisis and the impact that it has is going to promote for us to be creative and innovative into how we continue our work and be able to improve the community health and population health without losing ourselves and our community health center in the process. So one of the things that I want to make sure we look at when we're talking about climate change and climate crisis and the different climate events or related emergencies is that they're not coming as something that impacts your community and you have an outcome like the deaths or injuries or infrastructure being damaged. You have policies and systems in place that act as social determinants of health or create that framework for the social determinants of health to flourish. And then you have outcomes. So making sure that we look at those impacts and stressors that we're looking now, like extreme heat, storms, flooding, wildfires, are stressors in our communities that we're going to keep seeing, that we have been seeing for the past 10 years or so. And the systems that are in place, including worker health safety and regulation, emergency management, immigration policy, and even climate policy, that provoke or promote that we have negative outcomes in the communities that are being impacted. That being said, not only the communities and the patients that we tend to, but also our centers and places of work and the programs that we want to implement or develop. Next slide. So speaking from a lens of opportunities and being in the innovation that you can work from your perspective, and the resiliency of both the community, patients, and the workforce and health center infrastructure, we need to see these climate threats as opportunity as well. Not only to be able to respond to them and be responsive to those emergencies, but also to improve our practices to be at least one step ahead of these different events. And I'm showing up rising temperatures. That's one of the threats that we're seeing, wildfires and hurricanes as one of the most highlighted issues, but not the only ones that we may see related to climate. Next slide. When we see climate crisis, you may see it from two different perspectives. It might be that the place that you are right now is not under pressure or high pressure of these climate events. It might be that your state or county or region is not being as impacted as other places, like let's say the West Coast, the Caribbean, or the Gulf. So there are two ways of seeing this. We can see, for example, histories, we can see some of the patient population that we may be giving service to being directly impacted and our community being directly impacted, but we may also see an indirect impact to our space of work or region of service when the persons who get impacted get displaced to the way the area that we're working. So the fact that you are not being right now constantly being impacted by higher temperature or flooding or wildfires doesn't mean that your center is not going to get impacted by climate crisis. So the resiliency piece and the understanding about how the system and how the global impact of these events have in our region comes from not only knowing that we are going to see a direct impact on infrastructure and patients, but also that we may see our workflow and or the demand of services going up by people who get displaced to our service region. Next slide. And again, this is the same topic. There's an expectation of seeing climate refugees and people being displaced from time to time due to, like, it can be through the storms, flooding, fire, or extreme temperature. But the point is that it's not something that is going to be a point in a region in the US or any other nearby area or countries, something that probably is going to be affecting you even though you're not being directly impacted by it. So when we're talking about being the innovation and thinking about climate crisis and resiliency, we have to think about internally as a health center and or human resources and economical resources, externally thinking about the direct community that I'm now serving, but also thinking a little bit ahead in terms of the communities that may be arriving to my service area due to an impact in other states or nearby regions. Next slide. Again, looking at who are the most vulnerable, and the piece of it, why I'm bringing this up is when you saw the previous slides, we were talking about getting to know and that in data and having the information to be able to be to have that innovation, to have that resilience. We need to know who are the communities and the population that you want to be looking at first and most, right? So for climate crisis, you want to be looking at elder workers, low socioeconomic level communities, pregnant women, patients or with chronic disease, and immigrants will be the most vulnerable in this situation. Next slide. And they're vulnerable because they have several characteristics. And remember, these are, although we may attach this to the individual specifically, remember that first slide talking about the systems and the policies. The reason why this is a vulnerability is because we have systems in place that are lacking the infrastructure to be able to get rid of those vulnerabilities and make sure that the community thrives and is able to let's say, resist or recover from this kind of impact. So cultural and language differences, low income, dangers and risks of occupation, migratory status, lifestyles, and access to healthcare insurance, regulatory protection, people with the characteristics of being low income or immigrants or people who are have a different educational background, maybe having additional vulnerabilities that make them less likely to be able to resist an impact of flooding, storms, wildfire, etc. Next slide. There's programs in our own health centers, and again, we're talking about systems, programs, infrastructure in place that may diminish the access to healthcare. So what we're talking about, again, the community that's being impacted and those individuals having not being able to use the tools available for them because of language, transportation, insurance, loss of income, digital divide, which was a big thing during COVID, discrimination or displacement, they're more likely to be unable to recover. And one of the main issues with climate crisis is that it's not something that is going to happen and you're going to get a 10-year break from the next disaster. If you live in a space or a high risk area, the likelihood of you experiencing more than one disaster in a 5-year time frame is really high. So not being able to recover and having been impacted by a secondary climate-related event is still gonna be keeping that population down and unable to recover and have negative health outcomes. So something to think about when we're thinking deploying new programming, doing our emergency response system or planning, and trying to foment the community to do that same preparedness process and have that preparedness culture for climate change. We need to think about the systems and how we can improve their access when something like a climate event or a threat, a climate-related threat is ongoing or is going to happen. Next slide. Looking directly at emergency planning and response, and we're gonna get to a specific case study with Puerto Rico. One of the things that we have been seeing in different areas of the US and the territories is that there are disparities in the way that we're having emergency planning and response. And when we look at, there's a need to be thinking in engaging communities into the baseline, the beginning of the planning, rather than just throwing at them a plan or an instruction on how they're gonna be responding to certain events. So we have seen evacuation information and training that's not in the language that they are speaking, or it's not the appropriate language. Some of the services and programs that comes after a disaster, we saw this in COVID, but also with Ian, with Hurricane Irma and Maria. There's a bunch of programs talking about renewable energy, about rebuilding houses, but then the most affected are not eligible for those services because of X or Y. There are different systems and structures in place that are not letting them being able to receive those services. There's also unsafe living to some of those communities. In Puerto Rico, we have a lot of housing that is placed in flooding zones, and there's been an issue to how to work with them in terms of emergency planning and response, but also resiliency and climate change adaptation. Access to healthcare during and after is a disparity. Not everybody's gonna be open to go to a health center or to a healthcare facility. So the delay on getting service or getting some response or medical attention may cause them to be a little behind in terms of how they're attending to the health. And recovery priorities. Recovery priorities is very important. I think the health centers do have a role in terms of advocacy and how they advocate for the community in terms of the reconstruction that comes after a disaster, not only for their own facility, but we have seen For example, there's a few research talking about bridge reconstruction and how it gets prioritized in areas of high income to fix the way, or let's say like the streets or the highway, and then areas of low income then get delay a few years and even like 5 to 10 years after other areas to be able to have that reconstruction. And it might seem something like not important enough, but when we think about health services and emergencies, we're thinking about that your chance to survive in an emergency where you need an ambulance to get to your home is gonna decrease if you have a longer way to get to the hospital than other communities. So if your main road is not being reconstructed, is not prioritized, and they're having you go through double the time road or like another way of getting to the hospital that is longer, your chances to survive or your chances to actually get to healthcare in time are gonna be really low. So you're gonna be affected by that. And there's a couple of research showing like how advocating for equal reconstruction and recovery have a direct impact on health services that is being received by the communities. Next slide. So our presentation, we want to highlight the community mobilization in Puerto Rico, and we're talking about failure, and I saw a lot of comments regarding funding and resources, and this is a super great example to talk about that. Puerto Rico, as most of you know, was hit by Hurricane Maria in 2017. It's like Hurricane Category 5. A lot of the health centers in Puerto Rico were probably the first responders to communities that got isolated. And one of the things that we took as lesson learned is that at that moment, at that point, it might be organic, is what we do, is our way of working, or passion and mission to respond to community. But the stakes of how much resources the community health centers and community health workers dedicated to respond to Maria was something that we, even though it sounds weird, we don't want to do again. Like, you don't want to have that kind of you don't want to have that kind of response again. You don't want to have to put all your operation towards having a community be rescue or respond to an emergency when you have like a community health center who hosts that is also impacted in infrastructure and that you need to keep up operationally speaking. So we wanted to work with health centers in Puerto Rico to promote community preparedness and integration to community health centers. And the innovation behind this was, we are not going to break the relationship with the community in terms of the need that the community has for the support of the health center, but we want to leverage the 2017 response to be able to create this in a more standardized, sustainable way, right? So you want the health center to be able to respond, but you want the community to be prepared itself. Next slide. So when we talk about the role of the community health center, this community health center in rural Puerto Rico became a liaison between government response and agencies in the community as part of the response and the outcome of the program. They did some mapping to make sure they were recognizing other non-governmental organizations and communities that are able to support in the ways that they are not able to sustain. Example, the supplies and that came on from the states and other places to help out communities after Maria. The health center was doing distribution. It was doing distribution of water, and that's some of the pieces that you may not be able to sustain in other types of emergency, and you want to make sure that your community health workers are focusing on healthcare and focusing on maintaining the healthcare, the community health center operations. So the time that it took away from the usual task and the burnout that caused the extra hours of being like a first responder. So you want to make sure that the community is prepared for the next time, but also to know that you're gonna be there to support them, but not expect that you're gonna be the all right, the one that takes care of all the responses through like two climate events. And then one of the things that we talk about when it's important to know after you do your mapping, that you understand what you're doing and the innovation that you want to put in place, the sustainability. It might be funding what you need, but it also means that we need to integrate some of the steps within the operation of the health center, rather than thinking of this new project might be climate crisis, it might be emergency preparedness, it might be COVID-19, but the new program that you want to implement needs to be integrated doing to make sure that we're responding and responsive to the threats that we're or our community are experiencing. Next slide. Challenges and key lessons. After 2017, we had what we call the Southwest earthquake. So all the community plan that they put in place at that moment basically went out the window, and we needed to regroup and look again at how we were going to prepare to kind of a different types of emergency. Sure, after that, a couple of months later, COVID-19 arrived. So doing meetings and doing outreach, and the role that we were having to be prepared for the next hurricane season was needed to be reframed. And shortly after that, Puerto Rico received Hurricane Fiona, which caused them to, again, review and get together with the community. The point with this is that it is a continuous process. When we're talking about reminder, we're talking about resiliency, we're talking about looking over and over our processes and making sure that we're closing the gap and making sure that we are changing and adapting to new information and new support throughout basically the year. The other piece is like this community engagement processes also bring some additional benefits to the health center. So when you're looking to improve a program, or for example, in this case with Hospital General Castañer, they were lacking, they were not being good at implementing a dental hygiene program that they had. And this system, this new community engagement actually did the way to create some trust with community in terms of, okay, now we have addressed one of your issues with emergency preparedness. This is the other program that I want you to be part of it. So talking with community actually opens up to make sure that they take place, that you're addressing some of the concerns for other programs. So make sure that you get community involved, but also the participation to be real. It's not about getting them to know what you're doing, but also to making them part of the process that you're doing. And finally, for funding, making sure that we have some system in place. Usually when we have disasters taking place nearby or in our areas, we know there's some funding available that is gonna come afterward, but it's better to have some kind of framework to make sure that you are being able to be responsive to whatever funding opportunity you have. So you can actually go ahead and hit the ground running rather than think about what you're gonna do and how you're gonna do it. And I think that's it.
Yes, thank you so much for sharing so in depth about these innovations and the impact they've really had. So thank you so much. Next, we'll hear from Diana Liu.
Hey, is this working?
Yes.
Oh my God, that's so amazing. Just so you all know, my internet is intermittent right now. I'm on my phone's hotspot. This has worked in the past, but if I need to turn off my video, I will. You can go ahead and go to the next slide whenever you're ready. But I just wanted to like follow up on what Marisa was saying a little bit. I operate from a social justice and community power building lens and framework. And so I talk about all of the work that we do from that perspective. And Marisa was talking a little bit about the importance of involving community in emergency response instead of just like throwing things at them. And like, of course, we should be doing that. And I actually think I would encourage you all to think a step farther. And I think where Marisa was starting to get at, like, how do we build community power so that the community itself has the agency to be able to respond on their own? And how do we actually like think about shifting our power that we have like at health centers and other public health entities to our communities, and building power, building community leadership, community agency that creates the sustainability that we need to mobilize quicker each time disasters happen. And to like also not even think about emergency preparedness as like something that is like a one-time thing, because our communities are often living in and dealing with persistent disaster of poverty, of racism, homophobia, there's food apartheid, redlining, police violence, and all sorts of other systemic inequities. And creating community power and like really fostering that is how we become sustainable. And I was going to mention this later, but I like love this one quote from one of our street medicine staff who said, San Francisco Community Health Center exists as a part of the community rather than apart from it. And I want to encourage all of you to start thinking about yourselves and your work like this. But a little bit about us. We are a health center. We do all the health center things. Our communities are immigrants. They are communities of color. They're queer folks, trans folks, unhoused folks, and generally people who are the most impacted by historical oppression and structural violence. Because our community is really unique, and I know all of your communities are unique, which is why sometimes it's hard to like, have streamlined ways of having innovation because all of our communities need different things. But at the core of our services, we really have to meet people where they're at. And our services are designed by the people that we serve. Like most of our staff are made up of community members or folks who were previously clients. A lot of community health workers in our organization are from the community, working with our communities, and they have been with these communities for a long time. We can go to the next slide. Okay, so the thing that brought me to San Francisco Community Health Center is how we address the social determinants of health, and beyond that, some of the systems change that we can kind of touch on. And it often doesn't look like medical care, and I think it really goes back to the foundations of the community health center movement and providing healthcare where and when it makes sense for our community, and thinking about healthcare really broadly. And I'll go into that a little bit later. We do this because I think it's like really honestly the only appropriate way that we can care for our community is that we have to recognize that context that they live in. If our doctors are prescribing medication to someone who has nowhere to put their medication because they live in a tent and that place that they live in is going to be swept by the city tomorrow, that's not appropriate treatment and it's not effective healthcare. So that's the community that is a part of our health center. And so we do the work that we do in the way that we do because that's the only way we can provide healthcare. Another really important thing I mentioned earlier is community power building. We believe that our community has creativity, that we have the ability, and that we have the power to create the change that we want to see. And we're the expert of our own experiences. And a lot of times conventional healthcare does not take that into account. I don't like even using deficit-based terms like underserved or vulnerable populations because I don't think it's representative of the power that we hold and the agency that we have. I mentioned a lot of our staff are previously unhoused. They came to us seeking community and belonging. And we keep seeing that over and over again when we give people the validation that they need, like just validating their existence, they can start to really thrive. And our services are by and for and of the community, not only because we know that is the only way we can be effective, but because we're building a community that cares for each other. So why do we do this? And I know we've been talking about resiliency in a lot of different ways, but I have really specific opinions about resiliency. Our communities are always asked to be resilient. We talk about resiliency and we wear it really proudly. And there's absolutely no questions that our communities are incredibly resilient. They're powerful, they're beautiful, but we live in a system that ultimately like benefits a select group of people at the cost of others. And sometimes it's intentional, sometimes it's not, but our systems and structures keep this status quo in place. And if we're not addressing those systemic issues and the systemic violence that our people face, then if we're not looking at the conditions that impact people's ability to live healthy lives, we're not truly healing people. We're asking them to live in a world that harms them, and if they survive, to wear their scars proudly. So I encourage everyone to think a little bit about resiliency and what it means. And like, let's start to vision beyond like resiliency for our communities and start demanding justice. Like we should be dismantling the systems that create these inequities and start imagining a new world, a world that we deserve, a world that cultivates justice and liberation, so that our communities have agencies that are activated, they're thriving, and they're full of joy. I think that like what has been so incredible being at the health center is that there's so much joy in the work that we do, and we don't talk about that enough. But we believe this world is possible because this is the work that we're doing. Next slide. And I know there's a lot more stuff on the slides I'm not talking through, but I'm just trying to get through everything as quickly as I can because I have a lot to say. So I want to actually go into like, what does this look like? The thing I struggled most through my public health journey personally was really around how do we truly heal people and have our communities thrive? And we talk about the social determinants of health and structural issues, but what does that mean for our health centers? So at Praxis, I worked with a lot of grassroots community organizers and social justice organizations, and it's really clear for them, how do you impact structural change? But what is our lane, as health centers? And what grounds me is just like going back to the community health center movement. It was community-driven, community-led model that brings healthcare to our communities. And the first health centers in the United States were at a public housing site, and also like creating a community garden so that we can like nourish our bodies, right? I also think about the Black Panther parties, People's Clinic training their community members on how to provide medicine because of the way Black people were treated at healthcare providers at the time. So it's really this idea of like social medicine that I'm really interested in exploring and kind of bringing our health centers back to. And you can look a little bit up the history of that. It's not a new concept, but we work in this paradigm that has increasingly over like the last 30 years or so prioritize a biomedical model and individual level behavioral approaches when the root cause of illness we know is inequity that is social, that's related to like our social issues, our structural issues, and political issues. So our approach needs to be social, it needs to be structural and political. And then from there, we can help with like the biomedical and behavioral stuff. Okay. Next line. Oh yeah, I love the chat. I always like the Jack Geiger line about prescription for hunger being food. I will talk about what I think is healthcare a lot in a moment and like super in line with that. So when I was applying to work here, one of the questions they asked me was, how do I reconcile all the work that we do at the health center that might feel like seemingly unrelated to healthcare? And it was an easy question because I was like, but everything we do is healthcare. So it's been a really good fit for me, but in a nutshell, what we do is we do all the health services. I'm talking more about like medical care, oral, mental health, and we do all of this with a community-based framework. We also provide social services, and I'll go into a few of our programs, but we understand how truly important these are in order to facilitate treatment that's appropriate for our community and to heal and empower our community so that we can create that world that we envision, and a world where we don't ask people to be resilient. And lastly, we do movement building, and we do this by building community power through our advocacy work, our policy work, and capacity building for other health centers. So let's talk about what this looks like in practice. We can go to the next slide. So we recently took over operations for San Francisco's only homeless shelter for trans women. Tame and Boone might actually be the only homeless shelter catering specifically to trans folks in the country. It is as far as we know. If you all know of any, please email me. I would love to connect with them so we can learn from each other. We don't really have peers in this space as far as we know. And that's surprising to me because of the proportionally higher rate of homelessness for trans folks. And I can't explain how beautiful it is to like see people there and them being linked to our other programs and also our wellness clinic and seeing them thrive and eventually get moved into housing. But I want to read a quote from our program director there. People experience interpersonal conflict, that is normal, but to go into a facility where people running it hate you, that's unsafe. Being forced to use the bathroom you do not feel safe using, what happens is that people will just leave. They would rather be on the street. At TPNC, at the very minimum, trans people get treated with the same dignity and respect that cisgender people receive automatically at conventional shelters. They have true safety and refuge. And another thing that I thought was interesting was I was having a conversation with them recently, and there's all this like heat on the effectiveness of like homeless services and like there's a kind of weird political climate here in San Francisco right now, and a lot of people trying to define what success looks like people who don't work in this space, who don't work with folks who are unhoused. And I don't even know how you like quantify someone's life, but we've been kind of defining our own metrics for success and what that looks like and trying to start to shift that narrative. And for us, success looks like one trans person living on this one less trans person living on the street facing violence because they're not treated with dignity at other shelters, one less trans person being forced to use the wrong bathroom, one more person in permanent housing. And I'll just leave with housing as healthcare. Can you share in writing the quote that you read from? Yes, I can. I kind of have my notes here so I don't forget what I'm saying. Okay. But we can move on to the next slide, actually. All right, so we also have a trans community center, which is so incredible. I think this might be the only trans community center in all of San Francisco, and it's called Trans Thrive. And Trans Thrive, like the space, the program is just beautiful. It's like run by and for and of the trans community. And honestly, like it feels like to me like what the future of healthcare looks like for us. And as a queer person, I've seen a lot of trans services and trans programs being regulated to like the peripherals, like even if they're in LGBTQ spaces, but trans experiences are so unique and their needs are unique. And as like an LGBTQ led health center, we recognize this and we expanded Trans Thrive by giving them an entire community center we created an entire community center and a separate drop-in space for those programs. And my colleague and director at Trans Thrive said, we know the assignment and we did it. We changed the narrative and how services should be received or perceived. Trans-led, empowered, there is a place that exists like this. We're making the system work. Our work makes it real that San Francisco is a sanctuary city. But the work at Trans Thrive is truly incredible. One of our programs called She Boutique is a program where trans folks can come and access like clothing, like a bunch of different fashion accessories. We get Sephora shipments, so there's like beauty products, and they can also access HIV testing and counseling, sexual health education. We link them to whatever care they need to be linked to. We recently had someone who was like, I'm gonna move back to Florida. I lost my housing. I don't really know what to do. And I don't know if I can survive in Florida. And we're like, no, girl. And we linked them with Taman Booten. So now she's at Taman Booten getting into permanent housing at some point, but also able to come to Trans Thrive and still join that community in those programs. And She Boutique actually has been adopted by CDC as an evidence-based strategy for healthcare for trans folks. So you start seeing how having people's identities being seen and being celebrated and all of their needs being addressed as being really critical to their healthcare. Next slide. Okay. So I'm totally missing a ton of chat and I will like go back and look at it again soon. But we are located in the Tenderloin. And if you have visited San Francisco or know about the Tenderloin, then you might have you might have some like ideas of what that means, but it truly is like the epicenter of homelessness, substance use, mental health issues, and HIV and other chronic issues in San Francisco. We are like literally in the middle of the Tenderloin. So we're within like the neighborhoods where there's a lot of folks lined up on the street, just like living on the street and using on the street. And it's just a lot of suffering when you're there. So we're witness to what's happening in the Tenderloin. And we have a program, our community living room, that is a drop-in that we created out of necessity during the pandemic because homeless people had nowhere to go. So, the CDC was like, you need to stay inside, like, don't be outside, try to, keep yourself safe. But people didn't have anywhere to go. So at the living room, they were able to access coffee, meals, and a ton of different programs. And, this continues to today. So some of the programs are like harm reduction and peer support groups, case management. We have art therapy where they like draw or like, design different things. We have street medicine. Our street medicine team sets up shop in the community living room so that people can access medical services there. And this program is like really about survival. So like if you're really talking about like getting people healthy, the first thing is survival, right? So we're doing it whether or not people like it. Again, there's been a lot of political heat on San Francisco and like the homeless crisis here. And if spaces like this didn't exist, people would suffer more than they do now. And our problems like obviously would just, continue to persist. But every day people come in and access whatever they can get. Sometimes that leads to medical care if they're ready for it. Sometimes it leads to housing. But before we can offer any of those services, like people just need safety and they need comfort and they need food. And in addition, like having this space and this kind of interaction with our community, people are way more open to accessing services in a physical location because they know that they're going to be treated with the same dignity and respect that we give them on the street. And over the years, the program has always also created a lot of community and belonging. Again, we have staff and community health workers who are formerly homeless working in the program, giving it back to their community. They know what folks are facing every day. And some of these people are just like incredible activists, like advocates for the homeless community. And just like, you just see them thrive, if they're able to get what they need and eventually like, get to where like you see them become the people they are, which is incredible. And I asked our program director what joy looks like for the community living room, because I think joy is such an important part of her work that we don't talk about enough. But he said a moment of peace, feeling of belonging, feeling of community, and building family. And we can go to the next slide. So I think you all have heard about street medicine at this point. It's really interesting because I was at HOP doing like innovative outreach practices, like write-ups, and like that's the first time I really heard about street medicine. And it's been incredible to see this team at work, and like the people working in street medicine are a totally different breed of like clinician than the people who like want to be inside a clinic. And they're just, all of them have just incredible things to say, but we have a really robust street medicine team. And what I mean by street medicine is primary care on the street. We don't do transitional or conditional care. Like we're building medical histories for people. All of our services, we started doing it obviously because we saw a need for it. Like this photo is from like basically in front of our building. I'm pretty sure I recognize it. So this is kind of the environment that our health center is in. And in our team, in the beginning, this is like a direct quote, was held together by duct tape and bubble gum. But since then, it has really grown because we believed in that work. And so now we have fully funded 2 full-time street medicine teams that go out Monday through Friday every single day and provide primary care. And they are literally out there saving lives and reversing overdoses, offering harm reduction services. We check on their overall health. We do labs on the street and we report back the results to them on the street. We provide the medication they need. And beyond this, like for a lot of people, this is the only way that they're going to get medical care. And if you are able to go and meet people where they're at, then there's an opportunity to change where they're at, but you need to go there first. And I have one last slide for the most part. Thank you. So lastly, we do work in health policy, and I think you all know what this is, but I would encourage all of you to consider health policy as a crucial part of your work too. As professionals, we're in a position to really like advocate for just policies and policies that actually include the voice and power of our communities, rather than just having those policies come from like top-down public health stakeholders. We know what our communities are facing, and because we are our community, and that is one way we can start addressing things on a systems level. And the last slide is just my contact info. You can email me. I'm just a comms person with a lot of public health opinions, but super happy to facilitate introductions to the people doing this incredible work, because it's just been a joy to be there. Thank you.
Thank you.
Did
Yeah,
my camera go out at all?
No,
Oh my God,
your
amazing.
hotspot is amazing. Yeah.
Yeah.
As is all the work of the San Francisco Community Health Center. You're getting tons of kudos in the chat. And so
I'm gonna go read them now.
as is Dr. Pagan Santana. So thank you both so much for presenting on this really critical information. Of course, like we can talk about the theory of innovation and scaling innovation, but hearing about your on-the-ground programs is really inspiring and really helps us all sort of conceptualize what that can look like. So there are questions in the chat, and some of them have already been answered, but I'll read some of them. So how do you recommend embracing failure in a low resource funding context when funding and resources are scarce? Leadership is often shut down to failure and wants certainty. Tharisha answered this by saying building collaborations with others that have experienced the same and have made some headway may be an option to assist the leadership in feeling comfortable to try a particular change, especially if the leadership can see the pitfalls experienced by others and how they overcame them. And I think that is a great answer. So I'll leave it at that. I'll be honest, the chat has been blowing up, and so it has been hard to keep track. So are any of my presenters, co-leads, has anyone pulled any of those questions? I'm trying to.
A lot of resources also being shared. When Diana was presenting, though, I know a couple of people had questions about, or that really amounted to how they can start what she highlighted at their in their locations, whether it's in West Virginia or Arizona. And so I think, you know, if maybe we could pose a question to both presenters about how, you know, what would they recommend in terms of where folks should start if they want to replicate some of the best practices or what they carried out in their communities. Maybe that would be a way to sum up a lot of what was coming through, in addition to resources that we'll collect and reshare.
Beautiful. I love that as a question. So I'll pass it to Dr. Pagan Santana and Diana.
Please jump in if you would like, Marcel. I think that, so it's funny you mentioned West Virginia, because I actually grew up in West Virginia, but I know that it can be really hard in those type of places, and California is a totally different state than a lot of those states. But I think a lot of our services was just like, we need to do something about this happening like in front of our doors. And so we decided to open up a drop-in center, or there was the opportunity to like work with like the city to take over a homeless shelter that wasn't doing well because of not having enough resources. The last organization I worked at was a fiscal sponsor. And so they kind of extended their organizational like resources and structures to help movement building organizations thrive by providing fiscal sponsorship. So I kind of think of health centers that way. Like you have a whole infrastructure and you have HR people, you have clinicians, you have wonderful like program managers and staff. Like there is like, you have the capacity to do a lot of this like social sorry, I'm totally blanking. The like social work that like other places might not be able to do, like some of the smaller organizations trying to run these shelters and systems. So I would just encourage you, like, if there is an opportunity to like support that, like with your organizational resources, to go ahead and do that, especially if you see a need in your community.
Yeah, for us, the type of projects that we just did, we took the opportunity of, again, a threat, something that happened that made me look back, like Hurricane Maria released a lot of funding. NCN got some of that funding and worked with the community health centers in creating a program, yes, but also part of the program was identifying how the infrastructure that was already in place could be could get better, right? Could be integrating these initiatives that were happening without any funding. So what happened is the centers were responding because they needed to. They saw their community suffering. They saw that there was a need. And at some point, that energy, that funding starts to lower down as an extra project. So one of the pieces that we did was to do SWOT analysis, do mapping, resources, and understand, okay, so now that I know this about my community, how can I make it be a good fit within my operation, within the resources that I already have, and that I know are gonna be sustainable, not dependent on new funding, not dependent on new strategy. And the piece, I think the key piece for resiliency and responding to like new emerging issues is that they will always fall within the scope of your operation, because that's how we work, right? We work with vulnerable populations. So a new emerging disease, a new emerging situation, a new climate event is gonna fall within. We just have to be creative and go on the table and figure where that funding, where that resource, where that program is that we can leverage and build up from.
I don't know as much about the clinical end of the work that we do, but I know that our PPS reflects the communities that we work in. And so there is a way to work with your like payers to like make sure you're appropriately compensated for like your community and what it actually takes to provide care for them as well.
Beautiful. Thank you both. I love both of those answers. Yeah, I just so appreciate both of your presentations and your focus on involving the populations that we're here to serve, and to be in community with in these innovations and in the care that we're working to provide. Thank you all so much for attending. Please do fill out the evaluation. Like I said at the beginning, many NTAP's National Training and Technical Assistance Partners work together on the SDOH Academy. And so your feedback is really helpful and important to us. Like I said, thank you to our audience for attending. Thank you to our speakers so much for sharing your wisdom and the incredible information. You are both doing such wonderful work, as are your organizations, and we're so appreciative of having you here. And that wraps up our SDOH Academy webinar series for this project year, and we're so grateful to everyone who participated. Thank you so much and have a wonderful rest of your day.